Right, good afternoon everybody and welcome. Now, for the last few days I've been obsessively scanning the news, checking there's been no sudden surge of infection or another new variant is not making its way across the hot fields of Kent. In other words, nothing that would have meant that today's guest for our 66th episode of the RSM webinar series would have a reason not to appear. Fortunately, the world hasn't come to an end in the last 48 hours and our guest is indeed here. Now, if you haven't by now actually recognized him, or don't know who he is, then frankly, you've really come onto the wrong webinar. So go and find out where you should be. So without any further ado, welcome Christopher, the Chief Medical Officer, and welcome to the RSM webinar. Lovely to see you.
Thanks for inviting me. Yeah,
it's a pleasure. So let's just get down to business. Now, Christopher, so last week you were speaking to the Association of Directors of Public Health Conference, and you said that the path from here does look better, but there are still going to be some bumps and twists along the road. So I thought we might start with a bump and then do a twist. So what do you want to start with, the vaccine bump or the new variants twist, which were the two you actually mentioned?
Might as well start with vaccines.
Okay, good. So I mean, this is for you to talk to us, not really to whatever you want to say, but I guess the first thing people are wanting to ask, and we're not taking questions, so we've had over 1,000 already, and we've done our best to log them, etc., and use a few, but it's just overwhelmed our system. So I guess in the first question on that, which a lot of people are asking, was that when was it, around Christmas time, you took a decision to extend the time period for the second dose of the two vaccines that we were using. And so this is now 3 months later. How, reflecting back on that, how do you think that's worked?
Well, I mean, I think, to be clear, I didn't take this decision personally. This is a kind of general approach that was taken by JCVI, which is the right to do it, but I completely agreed with it as it happened. I think all of medicine is about balance of risk. And I think when we think about only the risk on one side of an equation, we always end up not doing the right thing by the patients or the public, depending what kind of medicine we're doing. And our view was that the balance of risk was in favor of maximizing the number of people who got a high degree of protection, accepting that that would therefore mean that the people who were vaccinated had a slightly lower level of protection than had they had two vaccines. So essentially we were going to double the number of people who got, we estimated probably about 70% protection, which is fairly close to reality. I think it may be slightly higher than that. And that they would then wait a bit longer before they got the probably closer to 85 to 95% protection from a second dose. And if you do the maths on it, it looked highly favorable to do it that way. Now, this was not popular with some academics, many outside the UK actually. It certainly wasn't popular with some pharmaceutical companies. And I think some people just say, well, you just should be following where the trials are. But our view was, it's not about simply following a single study. What you've got to do is line up all the evidence that's there. And the evidence implied to us that by maximizing the number of people with a fair degree of protection, we would maximize the utility for the general population. And I think, looking back on it, I don't think that it has turned out to be the wrong decision. But we were open to the possibility it could have, and at any point, if it had looked as if the numbers were going against us, we'd have re-looked at it. As again, you always should in medicine, you should always re-examine whether you're making the right decisions.
And what new data is now appearing across your desk to suggest that it wasn't the wrong decision? So some people are actually asking specifically, how sure can you be? And, I've just missed that I should have had my second dose last week. Should I be concerned? Issues like that. So how confident are you that the data is flowing in the right direction?
So the thing which would have made this the wrong decision is if there were several things in my mind that in a sense were tests of this is not turning out the way we would hope. The biggest one was if there was any significant evidence of a rapid reduction in the efficacy of vaccines over time, such that you've actually given someone a first vaccine and then actually by week 7, they're largely unprotected. There is absolutely no evidence for that at all. In fact, what we've seen is that certainly for the AZ vaccine and probably for the Pfizer vaccine, the strength of protection continues to increase beyond the 21 days that from the first vaccine, beyond 21 days that is in the protocol, and then doesn't show any signs of waning. So I think that's the biggest one. And then the second one was that we thought it was likely that there was going to be a strong degree of reduction of onward transmission, but again, we couldn't be absolutely sure of that. Again, the data has tended to back that up. And then from first principles, we were reasonably confident that actually for many vaccines, you get a stronger immune response after the second dose if you delay it. That's true for many vaccines, actually. We had experimental evidence of that from AZ. We had indirect evidence from Moderna that RNA vaccines, it doesn't seem to cause any problems. We didn't have direct evidence from Pfizer, but there was no reason to think that was wrong. And I don't think anything that's happened since has undermined our view that that is likely to be just as good and possibly even better by having a slight delay. So I think that the data that has come out has been in line with what we thought was likely, but accepting that we couldn't be certain. And I think the biggest of those was, is there a waning of immunity? And I don't think there's any sign of that at all yet.
Okay, well, again, massively reassuring to everybody, including me. So I'm not sure it was you said that. I think it might have even been Pete Openshaw, who's often of this parish, and people are very familiar with him in this webinar. But I think he was asked which is the best vaccine. And he said at the end of the last year, the best vaccine is the one that you are getting, which made complete sense. Now, do you think that's still true? And I'm specifically pointing to a study I know you'll have seen from, I think, last week, from Australia, in fact, about differences in the prevalence of neutralizing antibodies between the vaccines, and suggesting that perhaps there are differences between them.
Well, I mean, there are technical differences between them, including, importantly, operational technical differences between them. Yeah. So, for example, AZ, it's an awful lot easier to use in than Pfizer is. So the differences aren't only clinical. There will be differences in side effects. In fact, we know there are between AZ and Pfizer, both pretty rare in terms of severe. Common side effects are slightly different between them, slightly not as much as you'd think, actually, I think. But in terms of efficacy, the lab data implies greater difference between them in terms of neutralizing antibodies than the clinical data does. And that, to me, implies that probably antibodies are not the only thing which is important for clinical protection. And if you look at some of the effectiveness data from Scotland in particular, which has got really good data system, England as well, if you look at the actual effectiveness over time, well, the first Scottish data actually implied that the AZ actually had a slightly better effectiveness under operational conditions than Pfizer. I think the difference was actually pretty marginal. But I think if the combined antibody and T-cell response looks to be, after a number of weeks, pretty similar between them against at least the variants we've currently got, which is the original variant and the B117 variant. I think open question on the South African, first discovered in South Africa variant, whether that's still going to be true. The neutralization data look different between the two vaccines, but I'd go back to the fact that actually the neutralization data and then the effectiveness and efficacy against severe disease and mortality don't appear to be wholly correlated. If you get strong neutralization, it seems protective, but lack of strong neutralization doesn't necessarily mean that. And I think neutralization data is an inexact predictor for quite a lot of vaccines.
So I think that's actually answered a question coming up later, but I'm going to ask anyway. It's from Maria Ron, who happened to teach me. So I picked her randomly, but lots of people asked the same question. So this is about, a lot of people are concerned that they either have or as doctors have noticed that subjects who've been vaccinated but are still without detectable antibodies after the first jab. Are there any implications for the individual? And I think you've just said no, haven't you?
Not necessarily. I think that
not necessarily, yeah.
Not necessarily. I think having antibodies, I think, is a pretty strong indication that you will have a high degree of protection against severe disease.
Right.
Whether they're acquired naturally through infection, which is obviously not the way we want it to happen, or through vaccination. But I don't think I would say that not having them proves that you won't. I think some will and some won't, because you've also got the T cell protection additionally. But I think it's dangerous to go ahead of the data on this. I think we'll have a much better idea of this in the next few weeks to maybe 2 months from around the world, and for several different vaccines. And my guess is it'll probably, if it's true for one, it'll probably be true for more than one. But I certainly don't think you should assume that if you have lower or no antibodies, that means there is no protection. It probably does mean you're more likely to get infected, and may mean you're more likely to be infectious, but doesn't necessarily mean you won't have protection from going into hospital or having severe disease or mortality.
Okay, thanks. That's very clear. Okay, well that's the bumps. Let's do a little bit of the twists then, which are related as well. But this is again the continuing concerns and interest in the issue of variants. And we've had Sharon Peacock a couple of times on, who's really good, very, very good. But there's still a couple of other issues to raise with you. I mean, again, just listening this morning, the Welsh First Minister, I get most of the script from the Today programme actually, and he was talking about how we've had to move forward, and the key thing he put forward was because of the threat from new variants. Now, I've heard you talk before, and you've said you always from day one knew there would be variants. I mean, it would be impossible it wouldn't be. And the questions I'm getting are split into two. Those who are following that, we always knew it's going to happen. Why are we so concerned about it? And the others said, this is a terrible threat and we should close our borders. And they link the two. I've lost the lady who asked me that direct question, but that is the question. Do the new variants mean it may be a long time, or indeed possibly forever, before we ever have reasonable travel across our borders? So where are you on that particular issue? Are we overreacting or are we underreacting?
So I think that let's just go back to your starting point, which is we've always known there would be variants. We weren't sure how fast they crop up. They're not as frequent as some viruses, but then COVID is clearly nowhere near as stable as, let's say, measles, where you virtually don't get any important variation over from 1 year to the next. So it's somewhere in the middle period. And the first set of variants are being benefited by being better at transmitting. That's what actually all the current variants that are moving, are gaining dominance, are doing so not because they can get around immunity primarily. It's primarily because they're better at transmitting than the alternatives. That's certainly our own B117 variant. That's definitely true. But I think it's probably true for the other major ones we're worried about as well. But in due course, they will get a selective advantage by being able to evade immunity to infection and to infect on to someone else. That's quite an important point. There's no selection advantage to killing someone. There's no major selection disadvantage either for this particular virus, but there is for some, but in this particular one. But the thing they want to be able to do is to infect, or they will do, because evolution pushes them this way, is to infect and to infect on. And so there will be ones that will evolve around that. That's absolutely certain, whether it's natural immunity or vaccine induced. If we scroll forward 2 years, I think we're going to have a very wide portfolio of vaccines, large numbers of companies incentivized to compete on the basis of who can be first to get one, or hopefully everyone in the world who wishes to vaccinated first course of vaccination, so we won't have the current very, very big deficit globally, and even in high-income countries, between those who'd want to vaccinate and those who are vaccinated. And we've got technologies, particularly the RNA technology, but to some extent some of the adenovirus and others, where you can turn around a vaccine to a new variant incredibly fast compared to how historically we've been able to do it. So I think technology will find a way through this in the long run. But we've got a period of risk between now and then, when really the principal effort, and rightly the principal effort of the vaccine companies is just to get enough vaccines full stop. And when we're not going to be able to respond as rapidly in terms of to new variants. And we also are unsure whether the vaccines that, this go back to your previous question, the vaccines that actually don't have a good response to neutralization, are in fact going to still provide a fair degree of protection against severe disease and mortality, which is really what we're all primarily trying to do. I would include in that long-term chronic conditions as well as hospitalizations and mortality acutely.
I get you. Yep.
We just don't know. So what we've really got at this point in time is limited capacity to respond, not no capacity, but limited capacity to respond, and what are potentially very high impact, but for each individual variant, relatively low probability events. They are always the hardest to actually make judgments about. So things where actually your level of risk is easily predictable, in a sense, it's quite easy to produce a rational policy. So what we don't want to be is in a situation where we look back in 6 months and say, if we'd only just been a bit more cautious for a month or two, we would have actually got through the whole population. We'd have understood a lot more. We'd know how to deal with this. We probably have a few variant vaccines on the stocks, but now we've got a situation where 2/3 of it are B1, 2, 3, 4, 5. I'm making that up. I'm just, some new variant. This is now getting around all of our vaccines, and we're kind of not quite, if not back to square one. We're a long way back from where we were. That was an error. So we're being cautious because we've got such a difficult situation to go through at the moment. I don't think, though, this should be seen as an indefinite posture. I think this is a kind of a matter of probably the next year or two whilst we understand how to do this and find a way of responding rapidly to variants.
And in that year or two, what will we be doing about that then?
Well, I think
how will we be?
I think that there's kind of, we have to accept that the idea that you can stop any variants coming into the UK at all is not a realistic starting point.
Yeah.
But what you can do is you can slow it down. And your big, and so, anybody who believes that they can actually just put up some border policy or some overall policy that stops the possibility completely is misunderstanding the problem set completely. But you can slow it down a long way. And there are two things just to think through. The first of which is, whilst our overall R is less than 1, which it has been for a period of the last sort of 2.5 to 3 months. Actually, new variants coming in don't have much of a foothold because they come in and they don't spread much, because what works for one variant works for another in terms of the NPIs. They're a very blunt tool, but they do work against basically everything. Once we start to actually open things up, so R creeps a bit above 1, which is what we anticipate is likely to happen, and we've got a bit further down the current roadmap, then if a variant comes in, it has the opportunity to spread, and if it starts spreading, if it's got competitive advantage, it'll outcompete others, and at some point it'll become more important. The second thing is that the more cases you import, the bigger the starting point it has, and the quicker you're going to get to the point. Remembering it's always doubling or it's halving in an epidemic. If it's doubling up from 1,000, then actually it takes a lot shorter time to get to scary numbers than if it's doubling up from tens. And so what we're trying to do at the moment is slow this down. And the way you do that with any border policy is you don't worry about any country that's got less than you have, but you do worry about any country that's got more than you have. And that's true whether you're talking about overall virus, which drives some of our border policy, or whether you're talking about variants. The UK is a net exporter of B117 variant, so other countries are understandably putting their border measures up against us to slow that down. We are a net importer of other variants that are a bit more of a worry from the vaccine point of view. And that's really what drives a lot of the policy when it's being rational, accepting that border policy isn't always fully rational.
Okay, well, your point's well made. I mean, I'm struggling a little bit with this one because obviously the English variant, as I'm afraid it's now being called across Europe and indeed in Scotland, is completely dominant here. So we've been through that, and yet things are now steadily improving. But if you just look around Europe, it is unbelievably confusing. I mean, we've heard what's happened this morning in France, and we've heard in Germany, etc., and things are going badly. Norway and Finland are going very badly. But Denmark, which has the variant, the English variant, whether it is or isn't, and yet seems to be doing fine. Is there any, discernible overall picture or trend you can point to? Because it just does seem remarkably contradictory.
Well, the first thing is that it is extremely, but probably I'll make a couple of obvious points. The first of which is we always believe that it's human agency that, due to deep incompetence, leads to things getting worse, and due to superb management makes things getting better. Actually, with an awful lot of epidemics, both on the way up and on the way down, there's a certain play of chance to it. There's also some important biological realities, of which the variance is certainly one. Things like population density are very important. If you look at the UK, there is an absolute straight line between mortality rates, where at the top of the straight line is very highly dense urban areas, and at the bottom of the line is very rural areas. There are some issues around planning and so on, but I think there's always a risk that what we do is we fixate on something and say that's the reason this is a lot. So, I can remember people saying, Germany was having an absolutely amazing thing because it was better at diagnostics than the UK. Well, the UK's got pretty good diagnostics, so is Germany. Germany is still having some difficulties now. It's actually got better diagnostic capacity than it had then. So I think there's always a danger to actually simplify this down to one or two things, when it's actually usually a large combination of factors, some of which are under our control, many of which are not. And more of it is chance than I think people are prepared to accept.
I think that's a beautiful answer. Indeed, exactly a year ago, we had Paul Cosforth on, and we all send him our best wishes. And I think he said that sometimes pandemics just do what they're going to do. It's his natural history of them is to be awkward. And I think that's partly what you're saying. And we assume agency where there is no agency, or where things are just inexplicable.
Yeah, we always have agency, but I think that we assume a complete agency, which is simply not realistic.
Okay, and then in that term, seeing as we unfortunately are very high in this variant, well, it's established now, we shouldn't be particularly worried. I'm sorry?
Well, it's our normal one, and we shouldn't be worried whilst the concern is high transmitting variants, which it is for most countries in the world now. At this point in time, we have the one that is either the most transmissible or certainly as transmissible as all the others. And therefore, anything we do for our own variant, which is now B117, because that's completely taken over, will also work against all the others. When we're talking about NPIs, when they start to compete on issues of vaccination, of course, that ceases to be true. We would then we might be in a situation where, counterintuitively, because we are more highly vaccinated, the relative advantage of a new variant might be greater in the UK than some other countries.
Okay.
And it therefore establishes itself. Now, in absolute terms, it would still actually probably go up at a slower rate because of the vaccination, but in relative terms, it might start to then get competitive advantage over B117. So I think it's quite if you project forward a year or two, the situation may change quite a bit, I think.
Okay. Now, I just want to quickly pick up something you mentioned, but didn't elaborate on, because Tim Ward's, Nabila Javed, and many others are asking this. This is about the difference. You said that there are differences in side effects between some of the vaccines. Do you just want to quickly outline your current understanding of that?
Well, I think there's differences in the kind of minor but common side effects.
Okay.
Which I think are, I think anyone who who's had the vaccine will tell you about. I think, for example, there is more headache reported with AZ from anecdotal reports and also from studies than there is with Pfizer, etc. And you could choose quite, the exact ratios of different side effects are rather different between them. On the severer side, I mean, I think that the two which are where there is at the moment, there appears to be some difference. The first, which is the one that emerged right on day one of our vaccination rollout, was for Pfizer, where we had several really severe near-miss anaphylactic reactions, which we have not had with AZ. At the end of day one, when midnight, June Rain and I were discussing this and just thinking, what are we dealing with here? Are we in a situation where every day, because this is small numbers, we'd already had several really dangerous near misses? That hasn't been a problem with AZ, but that's the reason why if you have Pfizer, you have to sort of sit around for 15 minutes because there is a big risk. On the other one, this is something which MHRA and JCBI and CHM and a variety of other important scientific bodies are looking at, is that for AZ, possibly it's a class effect, but the one we don't know about the other adenoviruses, but AZ for the moment, because that's the one we're deploying in the UK, the very low probability but high impact is a question around a heparin-like thrombocytopenia associated clotting events.
Yeah.
And there the question is actually basically, are they happening? Yes, they certainly are happening. Are they causal? Case unproven, but I think we should keep an open mind on that, and assume, may well be until, it's actually in my view until proved otherwise. And then what's the actual incidence? The incidence is clearly incredibly low, and therefore for meaning sort of low digits in a million, I think would be my current estimate. And therefore for anybody who's at significant risk of getting COVID, whether we're talking about anaphylaxis with Pfizer or this side effect with AZ and possibly other adenovirus ones, we would, the risk benefit is wildly in favour of vaccination if you're, let's say, an 85-year-old diabetic with liver failure. The closer you get to someone who's right down at 20 and otherwise blameless in their health, the more you have to think through these really very rare side effects that are severe, because the risk benefits might get closer to parity. So you do have to kind of think these through, and that's always be an issue but that's going to be true for virtually any other drug or operation or medical intervention, mental health intervention you can think of. There are always downsides to them. And what you're always doing in medicine is balancing risk against benefit. And the idea that there might be a point where actually there's a group you wouldn't look at. I mean, I, from the beginning of this, have been really cautious about making a policy on children getting vaccines until we were really confident about adults. And that's not because I'm trying to protect children specifically. It's just that children get so little problems with severe COVID that you've therefore got to have a very strong justification for vaccination. Whereas if you're talking about, so you're talking about something like measles, the whole age thing is completely the other way around. And then it's actually children who get the majority of the benefit. They're the ones you're going to want to vaccinate. So it's always going to be a matter of risk against benefit for particular patient groups.
Adam Finn this morning made that beautifully. If you were vaccinating children purely to protect adults, then it's a different game. But perhaps we might be vaccinating them to make sure they can go to school. It's a different game again. Yeah. And Johnny Bell said beautifully in his characteristic way, if you want to get blood clots, get COVID. Okay, we may come back to children if we have time, but I want to go on to what for me is really the big question and why we really want to hear from you. Well, there's every reason why we want to hear from you. But Amel Isaac has asked, is COVID here to stay? And the answer is yes. So I want to follow that on and say, what metrics are we going to have to use to decide when to increase or decrease restrictions, interventions, etc., given that we are going to have to tolerate some transmission now for the indefinite future? How are we going to decide how we calibrate, how we react?
Well, I think if you start from the principle, which I think the great majority of people who looked at this do, not absolutely everybody, there are people I respect who don't think this, but they are actually a minority view, that COVID is not going to go away. That this is now a disease that for the rest of our careers is going to be around. Then you've got to kind of work out, well, what's our rational policy to this? And here I think I would differentiate quite a lot between an epidemic stroke pandemic environment where once you get exponential growth, it's going to carry on doubling until such time as it runs out of people, which is where you start off with at the beginning of pandemic. And what you get with, let's say, seasonal flu, where actually, basically, it's the R in reality, not the R naught, but the kind of the RT, is a bit below 1 for most of the year, and then when the seasons favour it, it goes above 1, and you start to get cases. And every year, somewhere between, well, usually on average, somewhere between 7,000 and 9,000 of our fellow citizens die of flu, and most of them very elderly, a few of them very young, and a few in very high risk groups like pregnant women. Then every few years we get a bad flu year where 20 to 25,000 die of it, and it really dominates a lot of the hospitals. We get significant problems. The last time we had that was about three years ago in the UK. No one noticed it. It wasn't reported on the newspapers, but actually flu deaths over doubled in a year, and it caused a lot of pressure on the NHS. So it is clear that we are going to have to manage it at some point, rather like we manage flu. And I think when you say that, people then jump in and say you think it's flu. Well, it's not flu. It's a completely different disease. But the point I'm making is, here is a seasonal, very dangerous disease that kills thousands of people every year, and society has chosen a particular way around it. Where that is, when it reaches that point, and how we then manage it, and how low can we get? Because of course, all of us want to get as close to 0 deaths as we can. And I think people who say, what's the right number of deaths? And the right number of deaths is clearly none. So we want to get as close as we can. But the question is, how do you balance that against other priorities? That's going to be partly a medical question, and it's partly going to be a societal question. What are people prepared to put up with? What we've demonstrated in the last year, actually, is we don't have to have flu at all if we don't want to. Because the things we've done against COVID actually have led to virtually no, flu has not completely disappeared, but it's been incredibly rare this year. So what we've shown is we have NPIs that can get rid of flu. If next year we said COVID's gone away magically, but we've shown we can deal with flu, let's everyone lock down over the winter, I think the medical profession would not make itself popular with the general public. So what we've got to actually do is work out some balance which actually keeps it at a low level, minimises deaths as best we can, but in a way that the population tolerates, and do as much of the heavy lifting as we can by medical countermeasures, vaccines, I suspect possibly in due course drugs, things like that, which actually mean we can minimise mortality whilst not maximising the economic and particularly social impacts on our fellow citizens. And that's, there isn't a perfect point on this. There's always a point we can do a bit more in terms of interventions, have lower mortality, but also have, for the sake of argument, elderly people not able to see their relatives in a care home, people not able to go to school play, a whole bunch of different things, which actually all of us would see are part, students not able to go to university, which all of us see is actually part of a whole life, at whatever stage of life you are. And it's how do we get the balance of that right? And there are always going to be outriders in our own profession, and have been in the COVID all the way from the beginning. There were people who were saying lockdown, absolutely everything from the beginning, basically take away. And there were people who say let it rip, that's nature, what do you expect? These are all sensible people with professor in front of their name in distinguished universities. Actually, most people are somewhere in the middle of that bell curve, but those are perfectly respectable outer edges of the debate. And I think that we will find a kind of a medium within that.
Makes more than have a professor in front of your name to make you respectable, Chris. But I take your point very well. But you're not then saying then, we'll go back to kind of traffic light system, that if we go above 50 or 100 per 100,000 in Leicester or Liverpool or London, we will then lock down Leicester again and keep London open or whatever. That's not the future that you're projecting.
No, I don't think so. I think, though, what we will have to watch out for, and this is where the variants start to matter, is that society will not tolerate more than a certain number of people being ill. I'm not putting a number on that, but there clearly will be an upper limit, even if they know that it's going to go away come the spring, not this year or next year, but I'm just talking let's project forward 5 years. There'll be a certain point where they'll say, actually, we need to do something about this. This is looking really bad, guys. We know we can get on top of it. Let's do something about it. The area where I think we technically are going to have to pull the alarm cord is if a variant of concern comes in that we can see is now back to a situation it could manage unconstrained growth, because the immunological response to it is just not there.
Yeah.
But actually what we're seeing at this point in time is a ripple. And this is one of the problems, since I have the privilege of being berated by quite large sections of the press on this regularly, when you first say, I know there are only 30 people dying a week, but believe me, there are going to be hundreds if we let this keep on going, everyone thinks you're mad. Because most people don't intuitively understand exponential growth. They think of linear growth, and they don't realize how you move from a very small number to a very big number incredibly fast once you're on an exponential path. And all epidemics, when they're unconstrained by immunity, are on exponential growth. So what puts a limit on them is usually immunity or running out of people, if they're highly transmissible. So we're going to have to spot technically the ones where actually it's not obvious to people, lots of people are dying, but if we don't do something, they're going to. Society will make a decision about, under ordinary circumstances, kind of what is tolerable and what's not. and it'll be an interaction between those two.
Okay. Well, I want to then ask you, it sounds left field question, but it actually isn't. You just mentioned about flu deaths, and then you said, of course, that wasn't reported in the newspapers. Now, Audrey Arlen-Jones has said, I think it's time now to stop announcing every day the daily amount of deaths and diagnoses from COVID. It needs to stop. And I think from that, she's saying it's maintaining a sense of fear, etc. So I would ask you, do you think we should now routinely announce the deaths from cancer, heart disease, non-COVID infections, and so on, to give people that perspective for next winter and the winter after, and that we should stop, purely just projecting the numbers of COVID without any sense of reference or proportionality?
Well, I think actually the UK has got brilliant statistics on all of these things.
But we don't hear them, as you just said.
No,
nobody knew about the flu 3 years ago.
Yeah, but that's not because we don't report them. So,
okay.
So I mean, and the majority of the time when I give public talks, actually, they're not about COVID. They go unreported, but they're not about COVID. The last one I gave, for those who are interested, a week ago was about obesity. No pickup at all. It's a very big problem, actually.
Yeah.
But no one interested in that. So it's not that we're not saying stuff on other subjects, and lots of other, all of people on this call who are professionals will be the whole time making stuff. We don't actually set the agenda as to what are the public interested in, and at the moment, people report all of this the whole time. There will come a point when they will report other things in much stronger numbers on other issues, and that's a good thing. But I think we have to accept that what we shouldn't be doing is saying, well, we want to suppress the COVID numbers. I think it's a perfectly legitimate thing to say, well, can't we highlight still further the mass of data that, for example, is on the ONS site or PHE site or on NHSX and NHS digital sites, all of which have got massively good graphics and statistics on all the other major health problems that we're all wrestling with, which in the long run are obviously going to be more important. And actually, in terms of numbers of our fellow citizens who are very ill and dying, massively dwarf COVID. They do now, and they will for a long time. So, I'm sympathetic to the general principle we should be talking about the other stuff, and I do, but we should also be aware of the fact that what the papers are interested in is what they think the public are interested in. Public at this moment are interested in COVID, and they're interested in COVID because COVID is leading to a huge change in their life. It's actually it's much part of that as anything else.
Okay, I'm really conscious of time because I know when you say you have to go, actually you mean it. So there's lots of questions on the HSA, on test and tracing, on screening, all of those things that we're not going to get through, and on kids, and fair enough. But I want to ask one question. It's come from Ann Johnson, who I'm sure you know, but I think it's a good question for you because you're a thoughtful person. And it's this: so how do you deal with the inevitable frustrations of where science ends and policy begins?
Well, I don't think it's even a frustration. Actually, it's it is a reality of doing anything in public health. Is you're on a spectrum, and I think the key thing to do with this is to realize you are on a spectrum. There are decisions that are purely technical. A lot of decisions are purely technical, actually. I don't consider it is sensible for an elected leader, by right of their being elected, to make a decision about which drug is used for cancer or whatever. And then there are decisions which are entirely political. So a decision about whether the government invests in children's education, roads in the north of England, or the health service is a political. I have a view about it as a citizen, but my view is actually no better than anyone else's. I vote once every 4 years. Most of the decisions that I'm dealing with are between those two, and depending on how much where I think it is on that spectrum will determine whether I actually really forcefully insert myself into the discussion. If I think it's mainly a technical decision and I think political leader is trying to take it, I will say I don't think that's your call, actually. They can do what they want, but I mean, I can make it pretty clear that they think it's a technical thing. Equally, if it's primarily a political decision, it shouldn't be me trying to make a political decision for a political leader. Many decisions are societal, and if they're societal, they should be made by politicians properly. Quite a lot of them are a bit of both, and you have a kind of, we say where we think the technical side is, and then they have to make a decision on behalf of society and then justify it to Parliament and to the general public. And I think, provided you're respectful of the fact that you give Caesar his or her due, I think it actually isn't too frustrating. Again, if people are interested in an extended version of this, I did one of my Gresham talks is on the role of the state in medicine. That kind of lays out why it is that I think certain areas the public expects the state to act, other areas the public expects the state not to act, and then there's a contested area, and it's actually only in the contested area that this is problematic.
We will pass around the link to that. That's your Gresham College lecture. So last question, this is the one you're going to hate because you don't like you're a celebrity now, mate. You're going to be overwhelmed by invitations to go on Strictly, MasterChef, Desert Islands, and all that lot. And I know you'd rather eat glass. But one question, this is from Sarah Hughes. How do you relax?
Very boringly, by either going out into hills and mountains, or kayaking, or going for a run, which is an incredibly middle-class answer. But here we are. Or chatting with friends when I get the chance to do it. I have to say, Zoom social things don't do it for me quite in the way as I don't know for anyone. I think they're my business. I think they're second best, or they're a lot better than nothing for social. But yeah, hanging out with friends and just getting out, that is a pretty dull answer, but that is the reality.
Well, it's not a dull answer at all. It's the exact answer I would give. So we haven't gone through all the questions, and I should say the commonest one by a country mile reads, "This isn't a question, I just want to thank Professor Whitty," and just pass that on to you. So look, Chris, to finish off, you gave the Harveyan oration in 2017 called Triumphs and Challenges in a World Shaped by Medicine, and we'll put that on the link as well. And you talked about Harvey, and you said his particular strengths were empathy, logic, dedication to the public good, and courage. Now, you went on to say those things have not changed over time and as relevant now as then. And this is a bit you won't like me saying, I'm going to do anyway, that I think you yourself have proven the wisdom of those words: empathy, logic, dedication to the public good, and courage. So can I say, on behalf of the Royal Society of Medicine, and I'm sure this is a view that's shared by millions more, thank you so much for coming today, but thank you even more for everything you have done. And, I know you hate it. I can tell you're hating it now, but we're glad to have you.
Well, thank you. But I think the thing which I would say in return is I feel very, very proud to be part of our profession.
Brilliant. Okay, we'll let you go. Can everyone else just stay on for just 1 minute, just for me to remind you that next Wednesday, please join our In Conversation. Suzanne Hayward, the wife of the late Jeremy Hayward, another outstanding civil servant, by the way. That means you're going to get 2 in a week, the equal of the one we've had on today. We'll be talking about her book, What Would Jeremy Think? That's her husband, and her late husband. And then later on for this session, Roger will be hosting a session on Europe and the third wave, joined by our old friend, Walter Riccardi, the man who cancelled Italy's Christmas, together with new voices from Germany and France. So all of you still there, thank you very much for coming. That was a fantastic session. I assume Chris has now gone back to run the country, as we all hope he has. And we'll see you all next week. Goodbye.